I envision this panel today to be very interactive. So I welcome any of you to come up to the microphone and pose any questions. We also have some topics that I'd like to interview and ask each of our participants on the panel today, and that might spark some conversation with those of you in the audience. So as you heard from both the All of Us presentation and the California Precision Medicine presentation, the engagement and inclusion of diversity is being increasingly recognized as significantly important towards precision medicine research and really all research. And so I just kind of wanted to hear from each of you a little bit about your thoughts around diversity representation and really the dream, right, of closing health disparity gaps through all of our unique research opportunities. So Dr. Muir, maybe we can get us started with your approach in California towards engagement. You talked about trust building and really the value of the significance of that diverse participation.
Yeah, so we have really tried to include community members in all the projects that we do. I explain that a lot. But lately, there's also been a push within our own organization as we are, deciding RFP topics, as we are working through these working group projects to include community members as early as possible in those as well. So, trying to kind of learn what we're telling other people to do. It's from an equity standpoint, diversity and inclusion in research is really important, but there's also a very large kind of argument to be made that it's scientifically valid as well. There are lots of drugs that are metabolized differently by people with different genetic backgrounds, and a lot of these tests have been done on people only from European descent, which actually is a very small percentage of the population. This isn't all just like warm, fuzzy feelings. This comes down to data and the ability of medicine to provide the right treatment to the right person at the right time.
Dr. Brown, would you like to share your thoughts on diverse participation in closing health disparity gaps from the African American perspective?
Yeah, sure, definitely. Patient, that's a very interesting word. From our particular perspective, patient is only one point. We look at the individuals that we service as participants. We look at them as having a life, being involved in life, and in terms of being.
Go ahead, try again.
Hello, is that better?
Is it better?
Okay, thank you. Okay, I'll start back over again. We look at the individual. You still can hear?
Do you want to hold it? Have you hold it up?
Okay. How is this? Is this any better? Okay, thank you very much. We look at the individuals that we're going to serve as participants. We don't look at them as just patients, hospital, sickness. We look at them from the point of view of wellness. What kind of decisions they're going to make? Our particular program began with the thought that can we as African Americans actually make an impact with African Americans? What can we do as African Americans to make a decision for ourselves? And in terms of that, we began with a model from the 1950s, late 50s, 60s, of having African American churches serve as a base point to begin to do that. During the 60s and early 50s, the African American church was very important in terms of engaging integration. Now we're looking at the African American church as a network coming together as a corporate body and actually implementing some type of program that will actually have an impact in terms of health care for African Americans. Therefore, our particular program is pretty much a personalized precision health care program. To begin the program, I have a partner, and his name is Reverend Hubert Hutcherson, who's not here today. And in terms of Reverend Hutcherson and I, and my particular point of view of looking at things, we said, rather than just have the program based in Pittsburgh, can we take the program and have it go from urban, and also rural. So what he did was he contacted some other ministers, and our particular program is now geared to go from Chicago, Cleveland, Pittsburgh, Philadelphia, Baltimore, Sumter, South Carolina, and North Charleston, and looking at individuals. What kind of program did we want to actually put together? We wanted to have a program that fit within a biopsychosocial spiritual framework. We wanted to look at the entire individual. And in terms of that, we set up basic components. The first component is education. The second component is psychosocial spiritual. Third component is genomics. The fourth component is medical. And then we have pharmacogenomics and nutrigenomics constituting the 6 major points that we use. We're also looking at an integrated system where all of those components work together and the participant is at the center. So therefore, our program, instead of going this way, goes this way. Begins with the participant, goes around and comes up and ends with the participant having the option to call the shot. The participant participating all the way in terms of the entire process. An interesting point about that is we said, okay, well, where do we begin as a beginning point for all of this? And we said, well, you can't have precision medicine unless you have genomics. And so in order to have genomics, we said, well, where are we going to get the DNA and that kind of information? So we said, let us set up a national. Now, we're really thinking outside the box. We said, let us set up a national African-American biobank. And that was our major thought, and that was our major thrust. And as we speak today, I would say within 6 months, it's going to be a reality that we're actually going to have a major African-American national biobank in place to begin to collect specimens. And the next point that we had in relationship to that was, okay, we have a biobank, but we have to have the participants. So we looked at it and we said, if you don't have education, you don't have a program. Forget it. If you cannot educate the participants that you want to come in your program, you will not have a program. That having been said, we said, well, rather than just educate the participants that are coming into the program, let's educate the individuals that are going to be educating the participants to come in the program. And the first buy-in that we have, if it's going to be church-based, is to have the pastor assume the responsibility of being the chief educator for those particular participants that are coming from his particular church to participate. Along with that, a nurse, along with that, a administrative assistant. And getting back to the education point, and I've seen it in terms of reading, in terms of literature, is that trust is a very important point. You have to have trust. And the first part that we said in terms of having trust was that if the individual coming into the program does not understand what this is about, they are not going to trust it. And if they don't trust it, forget it, they're not going to use it. Therefore, what we wanted to set up was a means of educating the educators that are going to educate the other individuals. Given high technology and all of this, our particular program is here, and trying to consolidate. We are going to use technology. We are going to use web-based. And in that, we advocate not as much in terms of text, but we're very video-driven. We want to have as much video with narration incorporated in terms of the process. That's on the short run. When I say the short run, I'm talking pretty much about from, I would say within the next 2 years running that. Longer run, we are looking out in terms of what's happening into technology. And from our point of view, we are very much interested in what's called cinematic virtual reality, where we will actually set up stations at various locations where the individual snaps on that headset and takes the trip to actually be able to go into, see different things that physicians at the highest level are talking about, to actually experience what it's like to actually be in a pharmacy, to be able to see all of that as part of our total education program. So we're looking at things technologically, biobanking, and on the ground floor. And the ground floor being able to actually be able to communicate with that individual, not where we like to have them go, but where are they today? Where do we meet them? And to meet them at that particular point and move forward. I've talked so much, I'll stop right there.
No, thank you. That's, I think it's tremendously insightful and something that many of us are striving to gain, right? And to understand, how do we engage? How do we build trust? And that education is so critical, and recognizing that we need to come back to education always as a foundation, and to recognize the full biopsychosocial support of the individual as a human, beyond a participant. So I think it's an incredibly exciting program that you're building, and if I'm not speaking out of turn, I think you're interested in perhaps engaging some partners. So if any of you do see Dr. Brown, please feel free to
Sure,
engage in discussion. Dr. Beckjord, your thoughts from a public health perspective on the ability to leverage precision medicine to close disparity gaps as opposed to widening them, and the very fine balance that we tread there.
Sure, and I can build on the great comments that have already been shared. I think we have to look upstream and downstream. So clearly, representation of diverse populations in research is an upstream component of ensuring that the potential of precision medicine is positioned to equitably advance the health and well-being of everyone. And then downstream, as we use that research and translate it into screening, treatment, making sure that those interventions are equitably available as well. And perhaps even going beyond making sure that they're equitably available. I think if we were working from a baseline of equity, then we would be interested in maintaining equity, but we're not. We're working from a baseline of inequity. So I think beyond saying we have to make sure that we're, not exacerbating inequity, we have to promote equity intentionally, because we are starting from a place of inequity. But trust has been mentioned many times. How do we foster trust? How do we demonstrate trust to help diverse populations have the opportunity to participate in research, to ensure that diverse populations equitably receive the innovative treatments that come from precision medicine? And there's lots of ways to define trust, but one definition that I really like comes from the Trust Project at Northwestern University, which says that trust is a function of three things: benevolence, integrity, and competence. And I think all three of those things are inherent to good research and practice, but I think being specific about what it really means is important, and there are other good definitions too. But I will just say that part of what I think is so important about leveraging community settings where people already acknowledge and have experienced those organizations in the community to demonstrate benevolence, integrity, and competence. That leveraging those settings like churches, other community-based settings, to engage people in research, to educate people about the availability of new tests and treatments is so important, and it's part of how those of us working within the healthcare system, I think, can build trust by partnering with places that have already earned it.
Yeah. So with that intentionality towards equity and towards closing disparity gaps, we know that the first step is we must have inclusivity in our research and our clinical trials. So any thoughts or specific guidelines or recommendations on how to approach the inclusivity challenge and to ensure that we are achieving diverse recruitment? For all of us, this has been a massive, very intentional process, and so far successful. But any additional thoughts or words of encouragement for those who are engaging in the audience?
I will mention very quickly, I kind of glossed over at the end, the working groups that the Advisory Council has decided to put resources into. And it's, called equitable consent is the short term, is the short kind of word for it, the title. And what we have decided to do until we receive more external funding is actually to put together a website that will be for potential participants, research staffers, the ones who are actually doing the consent process, the researchers themselves that are designing the experiments, and also funders. We think that that's, there aren't a lot of resources for funders in explaining how it is that you get projects that do, that have authentic community engagement. And so we're in the process of developing a lot of that content right now, and also in the process of doing outreach to different communities in California, making sure that, we're coming at things from the right angle. A lot of it, unfortunately, is, especially for, I think, the research staff, is what we've heard is that they need to know why it's important. A lot of the research staffers, that was my first job coming out of college, was to do the consent process for research participants. And you kind of gloss over it, but you don't really know why. And so a lot of the work that we've done is actually putting together all of the case studies that tell us why it's so important. And and really putting that information out there. We're not trying to hide it. This is why it's so important. The Nuremberg trials and Tuskegee and Guatemalan prison study, and these examples just go on, unfortunately. So I think kind of owning that and recognizing that, yeah, in the past it's been really bad is really important as a way to kind of move forward.
Yeah, acknowledging the history. Dr. Brown, do you have any comments you want to add to that in terms of engaging for participation in the research to ensure diverse representation?
Yeah, in fact, that's part of our program. And part of our program is to encourage African Americans to become cohorts. And what does that mean? So again, part of our education program is step by step. And we're not looking at them to become cohorts here or there. We're looking in terms of the long study, sustainability. I've seen a lot of programs, they get started up, then all of a sudden the participants go away. And the investigators and the researchers have spent so much time, so much money in terms of setting that up. In terms of our education, that's part of our educational program, is to let them know that they are making a commitment and not a contribution. This is about them, themselves, their families, and future generations. Therefore, we are going to push forward in terms of African Americans participating in cardiovascular and cancer research studies within their own particular cities and particular locations. So we're going to be open to university research studies and them coming in. I know there's been a lot of talk historically and stuff. Well, African Americans, Tuskegee studies, other individuals. We're not interested in that. We're not interested in it at all. This is a new day, a new age. Either you're going to be in with precision medicine or you're not going to be. We're offering our particular participants a choice. And that's it. That's all it is a choice. If you don't want to take the choice, don't take it. If you want to go by plane, you want to go by bus, or you want to go by car from this step to the next step, make a choice. But in terms of us, we are committed in terms of our participants engaging and becoming part of the research process.
Can you tell me a little bit more about why you feel the church system is the best way to deliver this message?
I think, I don't necessarily say that it's the best way. So many things are running around my head, so when you have to say best, back and forth. I might as well be quite honest with everybody out there. People say it all the time. I heard from God. So you did. I was sitting there, I didn't hear anything at all. However, our particular program is God-driven. No ifs, ands, and buts about it. The pastor and I and the fellow ministers, we pray about it, we think about it, and again, as we're asking the participant to make the total commitment, we too are willing to make that total commitment, and it's God-based. We use the Bible. No ifs, ands, or buts about that. We use scriptures out of the Bible to make it relevant to those. This is not taking place in CVS. This is taking place inside a church. So therefore, it is church-driven. And in terms of being church-driven, we also say faith. Evidence of things not seen, substance of things hoped for. That's where we're going in terms of our particular individual. So trust, again, hey, they work with the pastors know them, the pastors know their families, and again, we're not looking at the short run, in and out. We projected that we're going to do 1,000 individuals in 2 years. That's all, just 1,000 in 2 years. We're going to dot every I, cross every T. There's going to be an enormous jump from 2 years to 3 years. 3 years, we've looked at the data, we looked at what our marketing and education program. I also should add something else to that. Our marketing program is our education program, and our education program is our marketing program. And as we talk to the individuals that we work with, we say, the future is today, and today is your future. And so we bring all of that in terms of one thing. 2 years, we're looking at 1,000 people. 3 years, we're going to 10,000. 5 years, we are going to be at 100,000 African Americans participating in our particular program based upon, again, our marketing and education strategy. And I can't emphasize, start at the top again, God-driven. We are working with some of the brightest and highest minds, not only in the United States, but also in Europe. It's a total wrap program that we're engaged in.
Thank you. I would like to talk a little bit about the interface of bringing these emerging technologies from precision medicine research back to the bedside, right? Back to the clinic, back to the patient. And as a clinician, I want to use evidence-based medicine, but I really want it to apply to the patient sitting in front of me. And I want to ensure that all of my patients have equal access to the emerging technologies from precision medicine. So, Dr. Beckjord, I'm really interested to hear about your thoughts about how do we ensure equitable access on the clinical side as we bring all of these back to the bedside?
That's a great question that I think has sort of a multi-level answer, but I suppose if I answer from the perspective of an individual working at a payer, that's part of an integrated delivery and financing system, we do, as folks have mentioned already today, have a comprehensive continuum here in Pittsburgh, starting with our academic medical research center through our care delivery system, and then an integrated payer to, I think, leverage that continuum in as quickly as possible. And we know that continuum sort of traversing it can take a long time, but trying to work as quickly as possible to get those discoveries into application and support it as part of healthcare delivery. So from a population health perspective, and within the payer organization, I think it's in some ways easiest for us to be thinking about a population health perspective. Our policy instruments are some of our most powerful levers for achieving equity in population health. Individual service delivery is critically important, but you can achieve population health impact through through those policy instruments, I think, a little bit more effectively. And so we have the opportunity within our ecosystem here in Pittsburgh to have our policies be continuously informed by the latest evidence generated through our healthcare delivery system and our university. And thinking about equity at the policy level and at every level is so important. So as we work collectively to keep our policies as sort of current and forward-thinking as possible as one key component of ensuring receipt of the most innovative and effective tests and treatment available, we also continuously think about how to build equity into those policies so that we can ensure their effect is equitable. So I think thinking across that continuum, leveraging our ecosystem and building equity into the foundation of everything we do, from a care delivery all the way up through a policy sort of level of intervention, is critically important.
Yeah. Any thoughts on that, Dr. Muir?
Not so much. I mean, I'm not a clinician.
Hopes, dreams that you would like to see as a patient. And
I was kind of just thinking about a few steps before that, and no, actually, it is applicable here as well. In order to get those treatments, if they are offered, one has to be able to get to a hospital, one has to be able to have childcare, one has to be able to take the time off work. And so, there are a lot of barriers to both participation in clinical trials and, the other side of it, the patient care. And so, I feel personally that it's in the purview of precision medicine to take those social determinants into account, and the effect that they have on population health and individual health is enormous. So that was kind of the thought I had.
And if I could just add, so a really powerful lesson that I had the opportunity to learn in the past year through the generous mentorship of Dr. Amber Johnson, who's a cardiologist here at UPMC, and who's done research in health disparities. She and I were having a conversation, and she asked me to consider rethinking the use of the word access and replacing it with receipt. So we talk a lot about who has access to care, but as you've just mentioned, Dr. Muir, there are, access is really multidimensional, and social determinants of health really affect access. And when we say things like African Americans access primary care less frequently than white patients, for example, which is something that we see in our data, the use of that word access implies that, it's intentional, it was a choice. We know there's so many things that actually affect the degree to which African Americans receive primary care less frequently than white patients. And I think we have, it was a subtle sort of, language change, but again, a very powerful lesson for me that I appreciated from Dr. Johnson, because I do think that it matters that we think about receipt of care, receipt of testing, rather than just access to, which is important. But if we're able to, I think part of what happens by making sure that access and receipt are more synonymous is our emphasis on equity, and understanding that some populations are going to need different, more service than others at the same level of access to ensure the same level of receipt. So I appreciate your point about the social determinants of health.
yeah, and I think actually this overall point is a great conclusive point for us today, and that I think truly to ensure access, equity, and receipt, we need to diversify our workforce. We need to diversify our clinicians who are delivering that frontline care, as well as our research investigators. And so I think this is something we all need to work together on to ensure happens in the immediate future. Anyway, I would like to thank very much our panelists today for joining us. If anyone has any questions, we are open to taking them. Otherwise, I would encourage you to reach out and connect with any of us today during the conference. And thank you so much for your time and attention. We have a question?
I do have a question.
Great.
Excuse me. So, especially for those of us who come from urban communities, obviously diversity is defined in so many different ways. One of the things that we were thinking about at the company that I work for is really about language and being able to offer access to people who don't speak English as their primary language. Can you give some thoughts on where we are in terms of being able to broaden our opportunities outside of English as the primary language for the people who live in urban settings?
Yes, so one, thank you for bringing up the recognition that there are so many ways that we can define diversity, geographic being one of them, language being enormous. And we are very fortunate here at the University of Pittsburgh to have Dr. Maya Raghavan, whose emphasis on her research is for English learners and language diversity and the importance of inclusion of translation services and interpretive services in our research. And I really encourage everyone to think about budgeting for that in their grant proposals as they go forward, to really intentionally think about language accessibility and translation services, as well as, again, diversifying your research staff who are at that frontline engagement, and if they are readily available to have cultural and language competency to engage underrepresented populations, that is critically important. Anyone want to add anything to that? Yeah.
Sure. I heard recently from a public health worker in San Francisco. I worry in these circumstances when that there's tokenization in language, and it was explained to me that that the character for the word screen or screening in like prevention is different if you are in Beijing versus if you're in Hong Kong versus if you're in Taiwan. And that is one example of how complicated it is. So, I know I've talked to people and in Spanish they have the, Univision Spanish that they use, and so that's kind of the standard that they use. But it's very, very complicated, and you can't just put one thing in front of one person and say, translate this, and think that you're done.
Yeah, needs to be vetted. Next question.
Dr. Massart, I wonder if I could ask the panelists to comment on how they see putting the work they're doing in the context of the One Health programs and the UN Sustainable Development Goals and Agenda for 2030.
That's a big question.
I didn't understand. I didn't hear it.
That's okay. If you can put your work into the context of responding to the World Health Organization priorities and their 2030 agenda. And you may not have thought through that before, so that's a new challenge for us to think about. I'm not sure if anyone has a response, or you may have simply thrown down the gauntlet for us to think about a new avenue.
I think it's a good question. The much of this work, there are sort of common threads that transcend local context, and understanding how what we do at a local level is aligned with priorities that we attach value to that apply to a global agenda, I think is important. So much of effectiveness, I think, is found through highly localized efforts. I think about Dr. Brown, you're working at a highly localized effort within a church, within a community that has its own fellowship and congregation and culture, and understanding that as a way to promote the bringing of this work to life into people who need it, right?
Sure,
That's a
right,
very,
exactly.
but much of what you're doing in one church, I'm sure, applies some of those principles, and some of those approaches will apply across all of the regions where your work is taking place. And you're already, working in a global context over to Europe too. So I know this is a very high level answer, but I think I would just again underscore that there's a critical importance of working and thinking locally with respect to promoting engagement in some of the ways that we've talked about. But if we attach value to what the principles of those broader global agendas, like through the WHO, are showing, then I think the degree to which we can align with them, at least principally, is one way to try to have some integration with that global vision and agenda, where there is, I think, a lot that's shared principally, even if some local implementation or activity has to be tailored to a local context, both here in Pittsburgh and anywhere that the work is happening.
Yeah, and it seems like even our current discussions around COVID-19 booster shots, right, and the responsibility of using those in a universally global, equitable manner reflect that very thought process. And how do we, again, apply that to our precision medicine emerging technologies?
I apologize for asking too broad a question, but I think that the 17 Sustainable Development Goals, in fact, address the comments you made, Dr. Beckjord, in looking at more, and Dr. Brown, in looking at more than just a specific genotype or a specific allele, but essentially enumerating very specific spaces where precision medicine can be a tool as opposed to the overarching umbrella. And in fact, I think the One Health programs and the Sustainable Development Goals are in fact our overarching umbrella. And precision medicine is simply a tool to move toward those goals. And so again, my apologies for asking too broad a question. I hope that was a little more granular in what I was looking for.
Well, thank you for the question, because I look forward to better familiarizing myself with those goals and appreciate the opportunity to learn more. Thank you.
Just very quickly, I think in comparing a lot of the goals that were set for 2020 with those set for 2030, there are a lot that are similar, but one welcome change which I have seen is the introduction and realization that the trans community really is very underserved, and there's so many social reasons involved in that, but also in healthcare. Someone who presents as a man can come in with abdominal pain and end up being pregnant, and that has happened before, and babies have been lost because of it. So that piece is one thing that I've noticed that is brand new that I really appreciate.
It's exciting. Well, again, I want to thank our panelists and thank our audience. And again, please connect with us throughout the day and enjoy your break. And we'll meet back here for our next session.
Thank you.